Very good evening. I'm Dr. Aruna Nambirajan. I extend a warm welcome to the first CPC of this academic session. So today's CPC, we have with us Professor Anurag Srivastava, who actually needs no introduction. Sir has worked for decades here. He retired as the HOD Department of Surgical Disciplines, AIIMS, New Delhi. Sir's interest has primarily been in breast and breast cancer, where he's developed multiple guidelines, initiated MCH courses during his tenure here. And Sir is currently serving as Professor of Surgery at Sri Gorakshnath Medical College Hospital at Gorakhpur. So very glad to have you here, sir. We'll start the discussion. I would also like to welcome, we have with us Professor N.C. Nair. So he's the HOD of Department of Pathology and a person who started these CPCs initially. Very happy to have you here with us.
Namaskar, good afternoon. I'm really emotionally overwhelmed by the love and affection that you have bestowed upon me. And it's, 31 years after serving AIIMS, this great institution, great temple of medical knowledge, Harvard of the East, as it is called. So let's start this session. And we are also honored to have Professor Nayak, who actually initiated the Clinical Pathological Conference at AIIMS after having come from Harvard Medical School, and also started case studies. So we are actually working with under his guidance to develop case studies similar to what he developed here. So here we have an interesting patient who presented with the dual pathologies of mammary gland as well as neck swelling. So in history, in short, the salient points are noted here. A lady postmenopausal, 10 years postmenopausal, lady aged 58, mother of 3 children, all breastfed, and she hailed from a hilly area of Jammu and Kashmir and presented with a breast lump as well as swelling in the neck. The past medical history of significance is the major depressive illness for which she was received some treatment for about 2 years ago. And we'll talk about that. And also had a cholecystectomy 20 years ago. The family history is of great significance here. Mother had throat cancer and father had stomach cancer. And on further interrogation, I found with the persons, doctors, seeing the patient, that उन्होंने कहा कि पेट में कोई गांठ थी, पेट में कैंसर और ऐसे गले में स्वेलिंग था. तो throat doesn't actually mean larynx. It could be any swelling in the neck. And similarly, pet, stomach is maybe anything in the, it could be colorectal, hepatic. So, but both parents had suffered from some cancer. Next. So she had undergone cholecystectomy, and probably the commonest cause is gallstone disease, and commonly stones are caused by cholesterol crystals, and cholesterols are associated, high cholesterol is associated with obesity, and the 5F, female, fat, fertile, and 40 to 50. So one of the F is fat, and that fattiness or obesity is associated with increased risk of 13 different types of cancer. The World Bank data from 195 countries shows that 13 different organs are at increased risk of developing some malignancy in obese persons. So she had probably obesity-related gallstone and later developed cancer. She also suffered from major depressive illness for which She received antidepressant treatments, and commonly used antidepressants are serotonin reuptake inhibitor drugs. And prolonged use of these drugs is associated with increased risk of endocrine-related cancers such as the breast, endometrium, ovarian cancers. So again, increased susceptibility for developing cancer. Physical examination revealed a lady with average general health for her age, probably in euthyroid state, because it was not mentioned whether she was hyper or hypothyroid. And the biochemical tests were also normal. So I assume she was euthyroid. The left breast revealed a solitary, firm, mobile mass, which was free from overlying skin and underlying pectoral muscle. Nipple areola and the major milk ducts were within normal limits. The ipsilateral axilla on the left side had a mobile lymph node, and the size given here is 23:11. And I assume that these breast lumps as well as the axillary nodes have been measured by vernier caliper. We have done some studies that how to measure the breast lump, and one title interesting paper is Measure Breast Lump Precisely with Vernier Caliper. The next examination revealed swelling on the left side, which was not separate from thyroid, it was mentioned. And so I assume it is a thyroid swelling. However, its mobility with deglutition is not mentioned in the examination. So that's very important to assess any neck swelling, especially in the front or the central part of the central region or central part of the neck, to see or examine the movement, upward movement on deglutition. And we have described a special method for examination of the neck swellings, which is a modified Rose method. And we learned it from our great teacher, Prof. L.K. Sharma sir. This is a special method of neck examination. And some lymph nodes were also palpable in the upper part of the neck. So we come to what diagnostic probabilities we can think of. So a list of differential diagnosis. So that's the purpose of pathological conference, I gather. So if you are not given any information, just a lady from India, what is her probability of having breast cancer? So the current data suggests that 25 per 100,000 Indian women would suffer from breast cancer. That's 1 in 28 Indian women from her lifetime will develop breast cancer, as opposed to 1 in 8 in US. So we are progressing towards that, but still much lower in India compared to the Caucasian American women. So the age-adjusted incidence is slightly higher, 25.8 per 100,000 women. And the data from National Institute of Cancer Prevention and ICMR Institute in Noida suggests that about 16% of all women will have their cancer in the age group that this lady belongs to, that is 58. So between 55 and 64, 16% of women, that's higher than the national average, would have breast cancer. So she is 58, so probably higher incidence. Now, what is her probability of having breast cancer because she hails from Jammu and Kashmir? Well, it is higher than the national average. And the data suggests that there are many reasons for that. They eat more of red meat, more of saturated animal fat, and use salted tea, namak ki chai. All these factors, along with sedentary lifestyle, probably increase the risk of breast cancer among the Kashmiri women, which is higher than the national average. The data is there from ICMR. So again, we are reaching a higher probability of breast cancer. So there are the other possibilities of a breast lesion. This could be a benign condition. Benign lesions are far more common than cancer in any community, even in India. And it has been found that the cysts of the breast, which may be often asymptomatic, just revealed on ultrasound, are far more common in the elderly age group, postmenopausal age group, because this is the time when the breast is undergoing resolution after atrophy of the ovaries. So cysts are perhaps the commonest lesion, space occupying lesion, you may say. It is not solid, but space occupying lesion in the breast. Traumatic fat necrosis, either due to seatbelt injury or some other trauma inflicted on the mammary gland, can heal by fibrosis and even calcification. Phylloid tumor is not very uncommon in this age group. We have operated some ladies around 60 with malignant phyllodes tumor. At this stage, it will be more probably malignant phyllodes. And recently, we are treating a lady with diabetic mastopathy. She's a 60-year-old lady with uncontrolled diabetes for many years, and she presented with hard lump of 1 month duration. My first impression was cancer. At 60, you think of cancer, but finally, it proved to be diabetic. So, diabetic mastopathy is although uncommon, but should be considered as one of the diagnostic differential diagnoses. Now we come to the neck swellings. We pay tribute to our great teacher and scholarly scientist, medical innovator, one of the earliest director and the chief of the Department of Pathology, and also later Director General of the ICMR, who did pivotal work in the field of iodine deficiency as the cause for adenomatous goiter. He coined the term adenomatous goiter. He did extensive. His team with Dr. Karmarkar, Dr. Pandav, and Dr. Kochupillai, and Dr. Ahuja from endocrinology did some great work, which is widely quoted worldwide. And it's worth reading his life on this article, Exploring Global Health Legacy of Dr. Ram Lingaswamy, a review of his life and contribution. And there is also a book written by Dr. P.N. Tandon, sir. It's in 2 volumes, and you should also read about life of Dr. Ram Lingaswamy. It's a book, and I was really privileged to read this in a library in Tata Memorial Hospital. So, how he was contributing to the growth of institute in general and Department of Pathology and thyroid disease in particular. So, take the story of swelling in the neck in lady living in Jammu and Kashmir. Well, it is slightly higher, and the national average is highest in Kerala, and second highest thyroid disease is noted in Srinagar and parts of the because the hill water is deficient in iodine. Because the iodine is a volatile substance, one of the halogens, it's volatile, and the sun on the Himalayas evaporates the iodine, and the water coming from the streams of Himalaya is deficient in water. That's why we have so many patients with iodine deficiency goiter in the Tarai area, or and there's a study quoted recently where Jammu and Kashmir women had 6,008 women were studied, and in every lakh population had higher incidence of thyroid disease, and the prevalence was highest in the age group between 35 to 49 years, and this is only second to the incidence noted in Kerala. Kerala has now the highest incidence of thyroid disease, high amount of iodine in water and in the food. Seafood is rich in iodine, and so is the seawater. So high amount of iodine is leading to thyroiditis, and thyroiditis is later leading to thyroid cancers. So probability, what is the probability of cancer in thyroid in a long-standing goiter? The average quoted figure is about 20% of all long-standing goiters will progress to cancer. Widely quoted type of thyroid cancer following goiter was follicular neoplasm, but the data from Sanjay Gandhi Memorial Institute in Lucknow, as well as from CMC Vellore, the endocrine surgery department, shows that papillary cancer is the commonest cancer among patients who have long-standing thyroid goiter. So papillary is more common. Now we come to the investigations, hematology, serum biochemistry, and all the hormones. I asked for serum calcitonin level and other hormones. They're all within normal limits. And so probably we are not dealing with any hormone related such as medullary carcinoma or calcium or within limits as well. Mammography revealed a Virat's 5 lesion. I was only given this report. So Virat's 5 lesion in the left mammary gland along with the enlarged lymph node in the left ipsilateral axilla. On sonography of the neck, revealed highly suspicious Thyroid's 5 lesion on the right lobe of the thyroid gland, measuring 7 by 6 millimeter across, and the left lobe was within normal limits. The fluorine 18 PET CT scan, positron emission tomography scan, which is based on the Warburg effect. Warburg in 1931 was awarded with Nobel Prize. He's a chemist in Germany. He was awarded Nobel Prize for describing Warburg effect, which means that the cancer cells live on glucose as their energy substrate. And the unique property of this Warburg effect is that in spite of presence of oxygen, they produce lactic acid. So lactic acid is usually produced in anaerobic glycolysis. Here, cancer cells, in spite of oxygenation, they produce lactic acid, only 4 ATPs. So that's Warburg effect. And Warburg effect results in positive PET-CT finding, active uptake. But we must keep in mind that any rapidly dividing cell, whether it's of malignant origin or inflammatory origin, will also have high uptake. So after wound healing, after mastectomy, after thyroidectomy, for about 6 weeks, our friends in nuclear medicine will refuse doing PET-CT scan because they'll say the healing cells will probably have increased uptake. So fractures, healing fractures. So PET-CT usually suggests malignancy, but rapidly dividing cells of wound healing or inflammatory origin can also have uptake. So this lady had increased uptake in the thyroid with non-avid lymph nodes in the neck and FDG avid lesion in the mammary gland. So based on these tests, now what is the post-test probability? So I was fortunate to be selected by the Inclin program of Rockefeller Foundation and studied clinical epidemiology, where we talk of pre-test probability, post-test probability, and likelihood ratios. So I'll venture into this language. So likelihood ratio is the probability of a test result in the presence of disease divided by the probability of that result in the absence of disease. And you can state it in an algebraic form like this. Likelihood for a positive test is defined as true positive rate divided by false positive rate, or you can also state it in terms of sensitivity divided by 1 minus specificity, or in terms of probability of test positive in presence of disease divided by probability of test positive in the absence of disease. So when a patient comes, पूछता है साहब अच्छा टेस्ट तो आपका आपने कहा मैमोग्राम पॉजिटिव है या पेट-सीटी में पॉजिटिव है, तो क्या संभावना है मुझे कैंसर है? फिर ये भी पूछता है क्या संभावना है मुझे कैंसर नहीं? आपने ऐसे ही मरीज अपने जीवन में एक्सपीरियंस में देखे होंगे जिसमें टेस्ट तो पॉजिटिव आया था लेकिन कैंसर नहीं निकला, ऐसा आपने देखा? तो हम लोग कहते हैं हाँ भाई देखा. So we express our ignorance and we say, so this is stated in terms of likelihood ratio. Probability of test positive in presence of disease divided by probability in the absence of disease. So we studied the detailed diagnostic test indices for breast examination. And this was perhaps the first study in the world because we had reviewed from America where some world experts in breast examination had mentioned this. This is the first clinical study. So we found that the dial of a clock method was the most valid and reliable method of breast examination. And this was published in Journal of Surgical Research. And so with that data, we found that the likelihood for a positive test for a breast lump for being cancer is about 3.3. So if I apply that data, you can see this, the likelihood ratio equal to post-test odds upon the pre-test odds. So our data suggests that clinical breast examination with a lump and a lymph node in the neck, in the axilla, we think it is clinically positive. So with that positive LR, our LR is 3.3. We apply this into this equation. Pre-test probability in an Indian lady is 30 per 100,000 population. That's the national average data of ICMR. That comes to 0.0003. We apply this, convert into odds. Pre-test odds equal to probability upon 1 minus probability. And this gives you the odds in that decimal. Post-test odds are equal to this. Pre-test odds into the LR. Our data from AIIMS showed LR of 3. 3 multiplied by this. This gives 0.909. So you convert into probability, post-test probability after a positive clinical exam. So you come, a lady has come, you examine her, you find a lump in the breast with a lymph node in the axilla. What is her probability of having a cancer? And that's given by this equation, odds upon 1 plus odds. And you put these figures, and so you find 47%. So we started with national average of a lady having 30 per 100,000 per lakh, 0.003 बहुत कम है. और जब हमने एग्जामिन कर लिया और अपना डेटा लगाया लाइवलीहुड रेशियो से, वी फाइंड दैट हर प्रोबेबिलिटी ऑफ कैंसर इज 47%. देखिए 0.003 से 47 पे आ गए हम लोग, just by a thorough clinical examination. So that's the beauty of clinical examination, and we must stress to our young colleagues that never ignore clinical examination. Patient आया MRI और PET स्कैन फिल्म से पहले वो मत देखिए, पहले हिस्ट्री एंड एग्जामिनेशन करिए. We use your clinical acumen first. So this is her probability, 47%. Now we apply mammogram. Mammogram reported Virat's 5. Virat's 5 has a pre-test, post-test probability of 95%. Virat's for 95% or more. It could be almost 99. So the probability of cancer still shoots up further. So this is how we should apply our diagnosis when you're sitting in the clinic. Our great teachers like Professor J.N. Pandey sir and Dr. Nath and earlier teachers in clinical epidemiology unit here used to stress upon us that use this method of arriving at clinical diagnosis, not just jump on CT and MRI. And when we apply two tests together, the sensitivity and specificity increases further. If we apply these two tests together, clinical examination भी कर लिया, mammogram भी कर लिया. Now what is that? That is called parallel testing in the language of epidemiology. So sensitivity goes up, but specificity goes down. Sensitivity goes up, why? Because एक test नहीं पकड़ेगा, दूसरा तो पकड़ेगा. So sensitivity, if you apply two tests, sensitivity of the combined joint sensitivity goes up. So that's the advantage of applying two tests sitting. Now, if we use AND rule means mammogram भी positive हुआ, clinical भी positive हुआ. That is called AND rule. The sensitivity is given by this equation. And now we come to this lady in index case. She had a strong family history. So what is the joint probability of thyroid and breast neoplasms? Well, this is the pedigree tree. And here we are. Her father had stomach cancer at age 70. Mother had throat cancer, which could be thyroid. It could be thyroid, it could be larynx. We don't know. उन्होंने कहा वो गले में था, तो गला could be thyroid. Again, at 70. So she is the index case here, 58-year lady. So it could be synchronous cancer, breast and thyroid cancer, and these are the other index cases in the family history. So this gives me three possibilities. Because we have a strong family history, I'll think of three possibilities as a genetically predisposed cancers. One is BRCA mutation, because breast cancer most commonly associated with breast BRCA1 or 2 mutation. So I'll think of BRCA mutation for causing mammary gland neoplasm, and for thyroid I'll think as an incidental, because in Jammu and Kashmir incidence of thyroid cancer is high anyway. Number two possibility would be Cowden syndrome, which is caused by P10 gene mutation, and number three is the Leo-Ferrari syndrome associated with P53 gene mutation. Let's review the Cowden syndrome guidelines. The recently guideline published in 2023, the diseases of anus, colon, and rectum are summarized here, and this is a syndrome associated with germline mutation of P10. P10 stands for phosphatase and tensin on 10th chromosome. That's the full name for P10 acronym. It's an autosomal dominant inheritance, and for the residents, I made a acronym BERT. Remember BERT. B for breast and bowel, E for endometrium, R for renal, and T for thyroid. So remember BERT for thyroid. And the criteria, major and minor criteria, have been described in detail. And this is a list of the major criteria published recently. And minor criteria are here: autism, colorectal cancer, a variety of other lesions. And then you arrive at a diagnosis of Cowden syndrome if you have three or more major criteria with macrophyly and this Lemaire-Duclos disease, which is a neoplasm of the cerebellum, very rare neoplasm of the cerebellum, or two or more major criteria with three or more minor criteria. It is similar to rheumatic fever. You remember, 2 major and 3 minor, like rheumatic fever. So this is how we arrive at the diagnosis of P10 related Cowden syndrome, Leaf-Romani syndrome, again the review recently published by Surya Edema, and it was described first by 1969 by two gentlemen, Lee and Framani, and together it's called Lee-Framani syndrome. It's associated with autosomal dominant inheritance, associated with tumor suppressor gene P53 gene mutation located on 17th chromosome. It's commonly associated with high incidence of sarcoma, breast, leukemia, and adrenal gland. An acronym SBLA is often stated here. And I've made a acronym for residents to remember labs. Remember labs, LABS. L say leukemia, A say adrenocortical tumor, B say all B's you can think of: brain, breast, bowel, and bones. And S for skin and soft tissue. So virtually whole body. Soft tissue is the whole body, skin is the entire skin. So you keep this in mind when you see a patient with Leaf-Romani. We had a patient with Leaf-Romani in our clinic a few years ago. She came with history of breast cancer. Father had bone tumor, brother had brain tumor. So brain, bone, and breast. It clicked the Leaf-Romani. We got the genetic testing. She had P50 mutation. She lived for about 5 years. We had a follow-up. And every year we will examine the whole body skin from top to bottom, front and back. We will do upper GI endoscopy, lower GI endoscopy, and also do whole body MRI. Whole body genetic dynamic, it's called functional or dynamic MRI is also recommended as part of, because virtually whole body is at risk for developing this. So that's Leaf-Romani. And again, diagnostic criteria have been stated, classical criteria. A young patient before 40 age, before age 45 presents with sarcoma, think of this: first degree relatives, siblings, or child having any cancer below 45, any cancer with 45. So that's diagnostic criteria published for, I had a 1 year sabbatical at the research wing of Tata Memorial, ACTRE, and I was fortunate to work with a gentleman who is a world-renowned authority in genetic cancers, Dr. Rajiv Sareen. So I worked with him. He was the director of ACTRE. So I used to attend his afternoon clinics for genetic. So we learned a bit of his techniques. And when I came back in 2011, we started a genetic clinic at AIIMS, and we had some publications, and this is one such publication. So, so the final diagnosis, ladies and gentlemen, genetically predisposed carcinoma of the left mammary gland, T2N1M0 disease, with papillary thyroid carcinoma. Why papillary? Because papillary is more common among the patients who have long-standing goiter, and she had some lymph nodes. So papillary cancer often spreads by lymphatic spread, so lymph node is more commonly, and probably associated with either Cowden or Leaf-Romani. Thank you.
Thank you very much. Now we can have some comments from the house regarding any alternate diagnosis or any questions for sir regarding his diagnosis.
So P10 mutation has been, we have a lot of P10 mutation in this case, gene mutation has been done in this patient.
I don't know. I am not the treating physician, but ask the treating team.
And how many patients we have seen there? The thyroid carcinoma and the breast carcinoma has been seen.
We want to hear the
So my question is whether the mutation, gene mutation has been done in this patient or not? P10, like Cowden syndrome. It has not sense.
Just invite some comments from Dr. Ankita with the
Good afternoon, I'm Dr. Ankita Singh, Assistant Professor Surgery. So I can take a question from the clinical aspect. So only genetic counseling is yet awaited as patient is recovering from surgery and awaiting a lot of investigations. And there was another question from you.
Online discussion.
Second question is whether we have come across some patients where both thyroid and breast lesions that turn out to be carcinomas have been seen in some patients?
Yes, so we do have our own experience. So far, we have seen 2 patients in the last 2 to 3 years, wherein patient had were diagnosed.
I'm here, I cannot.
So this is one case wherein patient has presented with both the lesions at the same time. However, previous patients, and though it is also reported in literature, usually the patient presents with the breast lump, and on further investigation, especially while we are doing a metastatic workup, is, I'm sorry, sir.
Just continue, please.
Okay, sure. And it is only after metastatic workup we get to know that there is another nodule, something suspicious in the thyroid, and it's retrospectively when we examine the patient, we get to know yes, there is another synchronous malignancy which is lying there in the thyroid lesion. But yes, we have seen 2 patients so far, excluding this patient.
So those 2 patients, whether we have done the accuracy of biopsy, what are the lesions in the thyroid at that time?
So, with the clinical suspicion of a thyroid malignancy, which is usually picked up on PET CT, the second which is usually done is the ultrasound neg, because it is going to pick up lot many other things which are not picked up on PET CT, which is the relation of that nodule with the surrounding structures, and the we can also guide the FNAC from that particular lesion, which is done ultrasound guided only. And in all the incidents, all the 3 incidents, we did find malignancy on FNA itself, and there was no preoperative dilemma before we undertook FNA in all those patients.
My question to Dr. Anurag Srivastava, in spite of all the cancer markers, what about non-microscopic disease? Anurag?
Yes, we mentioned that differential diagnosis of phylloids tumor, which is usually benign, about 70% of all phylloids are benign. And then cysts are very common at this age group. Traumatic fat necrosis following trauma either by seat belt or other kind of trauma to mammary gland can also lead to traumatic fat necrosis, which will present as a solid lump due to calcification.
What's the GP? There could be leading of the garden path.
Yeah,
There could be adoption, you know.
we mentioned that in the list. Yeah. Thank
So you possibility non-microscopic is possibility.
you. Sure.
No. Okay.
Thank
Thank
you.
you.
Thank you.
So there was one more point that I wanted to highlight. So a patient had presented to us with the PET CT report itself, but in that the lesion did not have an increased uptake. So SUV max was low and there was a doubt. That is where we went ahead to do an ultrasound and an ultrasound guided FNAC in this patient. I'll request Dr. Aruna to do. So,
Just for the sake of discussion,
sir.
is there any possibility that the primary in the breast and breast bone are metastatic?
Yes, so that is another differential, but it was only 2 lesions in the thyroid which were not FDG avid. So there will be another differential of having another benign etiology in the thyroid, which is otherwise far more common than having 2 synchronous malignancies, which is breast and thyroid.
Thank you, Dr. Subodh, for a wonderful question. So, this lesion is measuring 3 by 2 on clinical round, but I think 2.2 by 2 on imaging. So, such a small lesion, probably just T1 with a small lymph node, is unlikely to spread to the neck nodes. If it does, it first goes to the axilla, intermammary chain, and through the intermammary chain, when all the lymph nodes in the axillary nodal basin are overwhelmed, are saturated, they are full of tumor cells, then only the tumor cells will go to subclavian lymph trunk. From subclavian lymph trunk, they can go to the neck nodes. So it's highly unlikely. Thyroid malignancies from metastatic side from melanoma and other cancers are known. So we can have a metastatic lesion in the thyroid from either melanoma or some, any hematogenous malignancy is known. Lymphoma can be present. So lymphoma is another possibility. The lymphoma can present both in breast as well as. Yeah, so it can happen the other way also. But if you take the statistics, the national statistics show that the breast cancer is the commonest cancer of Indian population as a whole than thyroid cancers. So just by sheer statistics, we can consider that as a possibility, but not as a probability.
How is the patient doing?
We will discuss that after I reveal the final diagnosis.
Okay.
So your final diagnosis is synchronous breast carcinoma with a malignant lesion in the thyroid.
Most likely, the lymphoma and other tumors, leukemic deposits from she's just confirming with the discussion.
So in the pathology department, we had received 4 samples. The first was the ultrasound guided biopsy from the left breast lump. And then we also received around the same time the aspirates from the thyroid and the axillary lymph node, followed by a total thyroidectomy and finally a bilocal excision of the left breast lump. So this is the ultrasound guided left breast lump biopsy, which was done outside and submitted for review. We received 2 blocks and 2 slides. And as we can see here, that this is a core biopsy of the breast infiltrated by an infiltrating carcinoma. The tumor cells are in cords, nest, and they are infiltrating in a desmoplastic stroma. There is some moderate degree of tubule formation. There is moderate nuclear pleomorphism and occasional mitosis. And this is a higher magnification showing features classical of an invasive breast carcinoma, no special type. Ductal carcinoma in situ was not seen in this biopsy. Necrosis was absent. And on further subtyping, the tumor cells were diffusely positive for estrogen receptor, focally for progesterone receptor, negative for HER2/neu, and show a Ki labeling index of approximately 20%. So this was a luminal type B type of a breast carcinoma. Followed this, we also received the aspirate smears that were received from the enlarged left axillary lymph node. And these are the smears, they were highly cellular. And again, these are MGG stain smears and these are pathological stain smears. As we can see here, there is some lymphoid tissue in the background, but the predominant population are tumor cells. The tumor cells are very similar to what we saw in the biopsy, abundant cytoplasm, epithelioid cells, with some attempt at tubule and glandular formation. So this was positive for malignancy. We're seeing metastatic carcinoma in the lymph node. These are other smears, again showing presence of metastatic carcinoma cells in the lymph node aspirate. Following this, we also received thyroid gland aspiration. So if you remember from the ultrasound there were 2 nodules in the thyroid. The left thyroid nodule was much larger, had a lower Tirard score of 4, and the right-sided thyroid nodule was smaller with a higher Tirard score. The aspiration was done from the more suspicious right side nodule. And here again, the aspirate was very cellular. And here, unlike here also we are seeing a lot of tumor cells, but unlike what we saw in the breast, here you can see the architecture is a little different. It's more of sheets and papilloid fragments, especially here with anatomical edging. And the cytomorphology of the tumor cells are also different, more of finer chromatin with frequent grooves and an occasional intranuclear cytoplasmic inclusion. This is the pathological stain smear, again showing that these cells had abundant cytoplasm. Some of them tend to have even a columnar shape with very elongated cytoplasm as compared to the nucleus. The nucleus shows very fine granular chromatin with chromatin clearing, small conspicuous nucleoli, grooves, and occasional inclusions. And in this, we can also see some thick colloid in the background. So this was reported as suspicious for papillary carcinoma thyroid, because it had architectural features such as papilloid fragments, which were suspicious for papillary, and as well as the nuclear features. So this was Bethesda category 5 on cytology, and this was reported as such. I think imaging also showed an enlarged cervical right 1B lymph node, which was aspirated in-house. This was done in-house, and this was showed reactive lymphoid tissue, no tumor cells in this. So at this point, after this, once these reviews were done, next thing we received was a total thyroidectomy was planned for the patient, and we received a total thyroidectomy specimen. So this was a specimen, and as shown in the imaging, the left side lobe was larger than the right lobe, and these are the cut sections where we can see on the left lobe, just as what is seen in imaging, a larger nodule was seen on the left side lobes, and the smaller right side nodule. This was a nodule from which the aspirate had been done. And the size of this nodule was around 3 centimeters, and this was around 1 centimeter. So if you look at, I'll first show the sections from the left lobe of the thyroid. So this was a lesion on gross, a very well circumscribed, unencapsulated, homogeneous nodule, which was large, present on the left lobe. And these are the whole slide images showing how this is the compressed thyroid at the periphery, and this is the nodule. It does not have a capsule, and it is pushing into the peripheral, the thyroid at the periphery is being compressed. And on higher magnification, we can make out that these are made, this actual lesion is made up of thyroid follicles, which are benign appearing, of variable size with papillary projections. And on higher magnification, nuclei are very bland. They are not showing any clearing, grooves, or inclusions as one would expect in a papillary thyroid carcinoma. They're very benign, bland looking nuclear features, just follicular pattern. So these are the follicles, which are very similar to what is seen in the background thyroid as well. What we see, I'll show some more. So except that they are more uniform, a little smaller, but still variably sized. And again, on high power, there's no evidence of malignancy in the form of mitosis or nucleatypia, and neither are there any nuclear features suggest for papillary carcinoma. So this was basically a dominant nodule, or what was earlier used to be called as a hyperplastic nodule, happening in the background of adenomatous goiter. So now coming on to the other nodule, which was on the right side, which was the thyroid spine lesion. Again, on gross, this was a firm, hard, slightly harder nodule with sort of infiltrating edges reaching up to the edge of the thyroid, reaching up to the capsule. And this again, we can see that this is the nodule here, and this is a background thyroid showing adenomatous change with variation in the follicle size. And this lesion, as you can see, it seems to be infiltrating with a lot of desmoplasia, some inflammation at the periphery, and it is infiltrating into the thyroid parenchyma and also showing a desmoplastic reaction. There's another separately lying fragment here, probably come off from here, also showing how the tumor is infiltrating at the periphery, even into the perithyroidal fat. And this is a higher magnification of the same lesion, showing the tumor, which is arranged in the form of cords and some papillae in a desmoplastic stroma. A slightly higher magnification, again showing these tumor cells arranged in cords, tuberculae, and papillae. And this is the magnification showing how these tumor cells, they tend to be longer. They are more taller than wide, around 2 to 3 times as tall as wide. And if you look at the nuclear features, these are the nuclear features that are matching with what we saw on the aspirate. The tumor, the nuclei are enlarged, they are opened up, and very fine dispersed chromatin, small prominent nucleoli, and with frequent grooves. So these are classical features which are associated with the papillary thyroid carcinoma. And because of this appearance of tall cell morphology, which was present in almost all of the tumor, this was called as a tall cell variant of papillary thyroid carcinoma. The tumor did show extension into the perithyroidal tissue, but this was microscopic extrathyroidal extension. There was no gross extrathyroidal extension that was seen on the gross specimens. And the Ki was moderately high, occasional mitosis was seen, so this was still a well-differentiated thyroid carcinoma. In the same lobe, we also saw another small microscopic foci of PTC, which was a microcarcinoma around 1.5 mm. And this was the BRAF-IHC, since which is a surrogate marker for the presence of BRAF V600E mutations. And here we can see that these tumor cells are strongly expressing the BRAF VE1 antibody, which indicates that these tumor cells have the BRAF V600E mutation, which is a poor prognostic marker in PTCs, in papillary thyroid carcinomas. So on the thyroidectomy, the final diagnosis was papillary thyroid carcinoma, so tall cell subtype, bifocal, with microscopic extrathyroidal extension, and the other nodule was a dominant nodule happening in a background of adenomatous goiter. The stage was PT1, margins were free and no lymph nodes were submitted. Following this, we also received the excision of the left breast lesion within a week, and this was a breast conservation surgery that was done with a skin sparing. So this was a skin ellipse on top and a 7 centimeter breast lump. On cut section, we found a 2.5 centimeter firm to hard, again infiltrating tumor, which was lying around more than 0.5 centimeters from all the surrounding margins. And this on microscopy again shows features of an invasive breast carcinoma, no special type, infiltrating into the breast here, showing tubule formation in around 25% of the tumor cells. There were foci of ductal carcinoma in situ with comedonecrosis in some areas. Lymphovascular emboli was seen at the periphery. And the overlying skin was free, the margins were free. Although it was not required, we did perform immunohistochemistry to confirm that this is breast and not a metastasis from each other. So this is the GATA3 stain, which is a marker which is specifically expressed in breast carcinoma, which is expressed commonly in breast carcinoma. And this tumor is diffusely positive for the GATA3 transcription factor. And this is thyroid transcription factor, which is expressed in thyroid carcinomas. And here we can see that these tumor cells are positive for GATA3 and negative for TTF1, confirming that this is, of course, breast pyramid, although on morphology, it was not considered at all. That was a classical PTC, and this was a classical invasive breast carcinoma. In the lymph node dissection, 15 lymph nodes were present, of which 2 showed metastasis with extra nodal extension. And here the final diagnosis was invasive breast carcinoma NST, pathological stage PT2, PN1A, with all margins negative. So in this patient, the final diagnosis was that of a synchronous invasive breast carcinoma along with a PTC tall cell subtype, bifocal right lobe of thyroid. Yes, sir. Yes, sir.
Thank you, thank you. So, in a recent meeting on endocrine surgery conference at Vellore, we found that there are now variety of the new classification, histological classification of thyroid regions, and we will be using that for nomenclature of your thyroid region. So, still sticking to the old papillary, that follicular, next.
We do follow the latest classification. I think I can.
It's a very confusing, almost 15, 20, nomenclature.
Yes, we do use the new one.
I also
The
learned that.
terminologies have changed.
And the old term adenomatous goiter has been replaced by the nodular disease. Thank you.
Is the patient all right at the moment?
I'm not invited the clinical team.
Sir, at 1 month of follow-up, patient is doing well, and she has been planned for a radioactive iodine scan so that we can plan her for radioactive iodine ablation. And she has been registered under medical oncology for chemotherapy for breast cancer since it was early breast cancer. So we hadn't given new adjuvant, rather we had gone for upfront surgery. So she has to undergo both chemotherapy as well as radioactive iodine ablation. And also, since patient opted for doing a breast conservation surgery, so she also is going to need radiotherapy for the breast itself. So patient needs to be followed up closely, and we are doing that. Patient's doing well right now.
What about treating for family members, like daughters, etc., etc.? Has that been done? Family counseling?
So that is also updated. We do have a genetic counselor with us. So as soon as patient has been dated and is free of the initial investigations, we plan to do genetic counseling as soon as possible.
You see, because we are seeing few common factors running in the family. In our department, surgery and Dr. Mishra, Dr. Nath, they call to neurology. Their successors, sisters have come for CA or few cancer over about 20 years. So that is very important screening of this patient for in her progeny and her relatives for cohort cancer. So I don't know what are you doing about.
So patient is being planned for genetic counseling and further testing if patient is willing to do so.
Okay, thank you.
Thank you, sir.
That is a very interesting Anurag, as always, wonderful and very well researched. And the pathologist presented a very detailed update very well. And I'm so glad to attend this Zoom meeting after a long time.
Thank you. I wish you were here physically. Thank you. Thank you. Thank you.
For the breast cancer and the WBCA. The audience which is here should know that Dr. Raj is a great pioneer of the breast cancer surgery in AIIMS. What he did over the years, nobody can match it, And the audience listening here, the youngsters should understand the zeal and the zealous that she did in this work. Anurag, thank you again for this.
Thank you. Thank you.
So I'll just complete the discussion and we'll talk a little bit about multiple primary cancers, which is now a very common thing that we're seeing in our routine practice.
So much
We develop technologies. So multiple primary cancers, also known as multiple primary malignancies, it refers to presence of two or more different primary cancers in the same patient, might occur in the same or different organ tissues. And the pathogenesis of these multiple primary cancers is complex, but overall it has a very negative effect on the prognosis and survival of the affected patient. Now coming to breast cancer of course the commonest malignancy is women, and the incidence of a second primary cancer after breast cancer is somewhere between 4 to 16%, which is around 17% higher than in healthy women. And even among the second cancers that happen in breast carcinoma, the majority ones are the cancers of the other gynecological cancers, ovarian, endometrial, cervical. And among the remaining, we have thyroid, leukemias, lung cancer, and brain cancer. And the incidence of multiple primary cancers, for certain reasons, are because patients are surviving more. There is genetic susceptibility, environmental interactions, as well as the effect of chemotherapy, and also the increased screening procedures that they may be subject to. Now, when we talk about dual primary and thyroid carcinomas, there is a lot of meta-analysis as well as literature that says that yes, these two do occur commonly together, which is higher than what that would be expected. So there's a meta-analysis here that says there is an increased risk of thyroid cancer occurring as a secondary malignancy following breast cancer, as well as breast cancer occurring as a second malignancy following thyroid cancer. And there's a retrospective cohort study over a 40-year duration from the Netherlands, which shows that breast cancer followed by thyroid cancer, the patients tend to be younger as compared to the breast cancer alone group, and PTC and invasive ductal. These are the two most common pathology results for the second primary malignancies. And the most thyroid cancer diagnoses were present in the first year after breast cancer treatment and were mostly TNM stage 1. And when we compared the studied cohorts, what they did was they compared thyroid cancer followed by breast cancer as a cohort, breast cancer followed by thyroid cancer as a cohort, and isolated breast cancer and isolated thyroid cancer as these cohorts. And what they found was patients with double group tend to have better prognosis as compared to the single group. But of course, in this cohort study, we are not sure whether they were metachronous or synchronous, like in our case, where it was actually a synchronous and we do not know the thing. And the mechanisms by why they happen together, they remain elusive. Hypothesis could be that, this is the common hormonal influence, genetic factors like PTEN, the syndromic associations, environmental factors or therapeutic factors. And of course, the cancer screening also increases. More recent evidence, however, suggests that breast cancer and thyroid cancer are both hormone-related malignancies in women. And a more recent study says that most of the breast cancer that happens in thyroid cancer usually ER positive subtype, as was seen in our patient. And this could be a bidirectional oncogenic interplay that because both organs are regulated by the hypothalamic pituitary axis and they express common hormone receptors. So when I looked into synchronous breast and thyroid cancer, there was just one of very few studies, and this is one big study from China, where they looked specifically at synchronous breast and thyroid cancer. So here the risk of screening and chemotherapy is out, and we are only looking at these factors. And they found that this was a unique clinical subgroup, and these patients actually behaved aggressively. They tended to be younger as compared to patients with single breast or thyroid cancers, more commonly estrogen receptor positive, and had a family history of breast cancer. Unfortunately, this study did not tell the exact histology of the thyroid carcinoma that was found. And when I searched literature for tall cell variant of PTC in association with breast cancer, this has not been reported previously because the tall cell variant by itself is an aggressive variant with more frequent extrathyroidal extension, lymph node involvement, tends to present at an older age, responds very less frequently to radioactive iodine treatment. So anyway, so this patient anyway will need to be subject to more genetic testing and family counseling. So to summarize, a patient who presents with dual primary tumors, they pose problems in that they require meticulous pre-operative assessment because of the operational risk during surgery, tailored therapeutic strategies, radiology workup to identify the extent of both the diseases, and a pathology workup to see whether they are synchronous, metachronous, same primaries, dual primaries, and of course the genetic component of the germline test. Thank you very much. Can I even have?
May I request some comments and any questions from the audience? I request Professor Sunil Chimber sir. Okay.
So this was an excellent presentation. I just have two comments to offer. First is that we generally can determine the probability of a thyroid nodule being malignant based on the uptake. So had we had a look at the images, probably we would have been more confident. For FDG-avid nodules, the probability of malignancy is 30%. So that's the first comment that I would like to make. And there was a question regarding, second malignancies. So on PET scan, this is not an uncommon scenario for us, and probably every week we end up seeing about 3 to 4 cases with dual malignancies. So whether they are acted upon or not is a different scenario altogether, because we find that many times we mention about thyroid nodules which are avid, and again the patient comes for a PET scan 1 year down the line, and again that nodule is still persistent. So if we were to actually chase down these nodules, probably these kind of diagnoses will become more evident. But we aren't chasing them as frequently.
Can I just ask a question? So, earlier you used to do thyroid scan, thyroid scan, dean or even technician. So that has stopped. Not PET, but radio ID.
We still do technician thyroid scans, only that it's no more done for this particular condition, whether a nodule is malignant. Conventional teaching says that if you see a cold nodule, the probability of thyroid malignancy being present is around 20%. But subsequently, literature has improvised and we have better diagnostic techniques. So these days, according to most guidelines, I think all guidelines, in fact, the thyroid scan is not indicated primarily in the evaluation of a thyroid nodule for determining.
Graves used
That means any woman coming up to the age of 50 with thyroid nodule should be investigated for breast cancer at the same time.
No, I don't think so, but the clinician might answer.
What do you have to say?
They should. The government of India, under the National Health Mission (NHM), guidelines are that any person, lady, aged 30 to 65, should have a screening by clinical breast examination and history. And if there is family history, then also should have MRI, and then lesion should be biopsied if one is found. So national guidelines suggest that you should always evaluate the mammary glands, because that's the commonest cause of cancer in India, and commonest cause of, sadly, death due to cancer, cancer-related death among women. So,
Thank you.
Thank you.
Well, I request Professor Sunil Chimber sir, Head of Department of Surgical Disciplines, to kindly conclude the remarks.
Okay.
Hello. Namaskar. This patient had come to us, and the unique thing was that she had two kids. And I have been doing thyroidectomies for a very long time, and I have not come across a patient who had thyroid cancer and simultaneously had a breast cancer. So she was unique in that particular. And I think the person who could have tied both of them together is Anurag Srivastava. So we got him to come here and discuss this case. The patient is doing very well. She had undergone a total thyroidectomy, and I think we had really done a good job at that. She had some hypocalcemia in the post-op. She recovered out of that. And then she underwent breast conservation surgery. That also she has done very well. She's on follow-up. She'll get treated. We'll look up the family, what's happening. We have the person sitting with us here on the audience. Kindly raise your hand. There is Harley. She does all that for us. I am not very sure that I have seen another patient in the last 30 years who had a thyroid cancer as well as breast cancer.
Yes, that's it.
So I would really like to know if somebody else has seen that, whether pathology can tell us.
They will have to get the approval.
Dr. Nima,
Not synchronous. Not synchronous.
So if a postgraduate will make a diagnosis in the exam, we always teach them and try to justify the two of with one diagnosis. If he will make two diagnoses, so he will likely fail.
You know, Dr. Subodh, you have touched upon a very new area, which I think is going to happen to all of us.
Yeah.
And you know, the earlier teaching that you should have one common pathology to explain
Yes.
all the
That's
symptomatology. I don't think that holds true anymore. So the same gland can actually have two different pathologies occurring at different times or even occurring at the same time. So I think that's where you know comorbidities have come in and they are listed as a part of the diagnostic process. Thank you so much for intelligent and I must congratulate Dr. Anurag for this.
Thank you, Professor Chumbar, for being a wonderful breast and endocrine surgeon. See, breast is an endocrine organ. People were, questioned why you include breast surgery or breast disease treatment in endocrine surgery department. Breast is an endocrine organ. Breast is the target for so many hormones: estrogen, progesterone, prolactin, oxytocin, cortisol, insulin-like growth, and also produces hormone. You know, the breast tissue, the fatty tissue, adipose tissue produces estrogen by peripheral aromatization. So by definition, breast is an endocrine organ. It's the site of target tissue of several hormones and it produces estrogen. So thank you.
Doctor, and the department for a wonderful CPC.
Thank you, well done.
Thank you so much. Dr. Nima,